So from the oxygen flux equation, remember oxygen flux equals cardiac output multiplied by oxygen saturations multiplied by hemoglobin concentrations. From this equation we can see that if we increase the hemoglobin concentration, we can also increase the oxygen carrying capacity of the blood. And this will happen over time. Now, we already know that the levels of oxygen are detected in the chemoreceptors in the aortic arch and the carotid body and carotid sinus. But as well as that, do you know where else in the body that oxygen levels are detected on a longer term basis? No, there's another organ in the body that can detect the levels of oxygen going through it. Well, if you haven't guessed it, I'm not surprised, because it's actually the kidney. So the kidneys are able to detect the amount of oxygen going through them. So the kidneys sample the arterial blood going into them, and they estimate the amount of oxygen in that arterial blood. And if the amount of oxygen in the arterial blood going to the kidney drops, the kidneys respond by releasing an endocrine hormone. Called erythropoietin. Sometimes it's just called EPO. So when the level of oxygen in the renal arterial blood drops, the kidneys respond by producing this endocrine hormone called erythropoietin. Now what erythropoietin does, it's an endocrine hormone, so it's going to circulate all around the body, of course, and particularly it circulates to the flat bones, and it circulates to the end of the long bones. So here we have the end of a long bone. And of course in the flat bones and at the end of the long bones, what have you got at the end of them here? Well, at the end of long bones and in flat bones, you've got the red bone marrow. And it's the red bone marrow, of course, that's producing the blood cells. Most of the cells produced by the red bone marrow are the red blood cells. So the erythropoietin stimulates the red bone marrow. And it stimulates the red bone marrow to produce more erythrocytes, the red blood cells. Remember, these are biconcave discs. They're darker on the outside. They're lighter on the inside, because if you look at them from the side, they're biconcave discs. This makes them flexible so that they can squeeze through small capillaries. But of course, it's the erythrocytes that carry the hemoglobin. 98, 99%, probably 99% of the blood, of the oxygen that's carried in the blood is carried by the hemoglobin in the red blood cells. So if there's more red blood cells, that means there's more hemoglobin. What's that going to do to the oxygen carrying capacity of the blood? Well, if there's more hemoglobin, the blood can carry more oxygen. So if the blood levels of oxygen are low, erythropoietin is produced. Erythropoietin stimulates the red bone marrow. In response to stimulation by erythropoietin, the red bone marrow produces more oxygen-carrying red blood cells. This is not an instant response. It's not quick like the cardiovascular and respiratory response, which take a second or two. This is going to take a week or two to develop to a significant amount of red blood cells. But when the amount of red blood cells increase, that's going to increase the oxygen carrying capacity of the blood. That's going to increase the amount of oxygen carried in the blood. And of course, one of the places the blood is going to go is to the kidneys. And if there's more red cells carrying more oxygen to the kidneys will recognise that there is an increased amount of oxygen in the blood, and the kidneys will respond by producing less erythropoietin. That means there'll be less stimulation of the red bone marrow and less new red blood cells will be produced. So this is kind of a homeostatic mechanism, really, for regulating the numbers of red blood cells in the circulation. So in this red cell response, we're getting increasing amounts of haemoglobin in the blood via the erythropoietin mechanism. This will happen, for example, if someone goes and lives at altitude. If you go up a mountain and stay there for a while, where there's a lower partial pressure of oxygen in the atmosphere, there'll be less oxygen in the blood. That'll be detected by the kidney. The kidney will produce more erythropoietin, and you'll produce more red blood cells. Some athletes do this for altitude training. They'll go and train at altitude, get more red blood cells, and that will improve their aerobic capacity because they can carry more oxygen. And now there's a synthetic form of erythropoietin called EPO, which you can inject. And some athletes have actually used this to cheat. They've injected themselves with EPO. That's increased the amount of red blood cells they produce, and that's increased their aerobic capacity. But it's a dangerous thing to do, because when you make more red blood cells, the blood becomes thicker and they're more likely to get thromboembolic complications. And as well as that, because the blood's thicker, it's harder for the heart to pump it out, and that can over time lead to heart failure because it causes an increased ventricular workload. Pathologically, an increase in the number of red cells is called polycythemia, too many red cells. Now this can occur idiopathically, but it can occur, that just means we don't know the cause, or a primary condition where you can just get it. But very often it occurs secondary to other conditions. For example, patients with chronic obstructive pulmonary disease aren't getting the oxygen in their blood, so they get this erythropoietin mechanism. And patients with chronic obstructive pulmonary disease can become polycythemic. And again, that predisposes them towards thromboembolic disease. They're more likely to get thrombosis and subsequent emboli formation. Patients with congestive heart failure as well, as we've said, they can get a stagnant hypoxia. Again, that can stimulate the erythropoietin mechanism and they can become polycythemic. And that's particularly unfortunate, actually, because as well as being more prone to thromboembolic disease, because the blood's thicker, it's going to make the heart even harder to contract. It's going to increase the myocardial workload because the blood is more viscous. Now, in renal failure, the opposite actually happens. If the kidneys aren't working, the kidneys can't produce the EPO, and patients with chronic renal failure can become anemic. Now, when I was a student, we used to give these patients blood transfusions. Now, if it's available, the treatment of choice is to give them the EPO injections, and that will increase the amount of red cells they produce. So that's pretty well the end of the talk on the body's compensatory responses to hypoxia. It's worth just mentioning that if a tissue is chronically hypoxic, more capillaries will grow into that tissue, and if more capillaries grow into the tissue, then more oxygen can be carried. And this is part of training. If you do a lot of running, your leg muscles will grow more capillaries and more blood will be carried to them. Another mechanism is that there's an increased amount of myoglobin produced inside the muscles. And the myoglobin inside the muscles increases the storage capacity of those muscles. But actually, probably, most of the changes to hypoxia that allow people to adapt to low oxygen levels are intracellular changes. There are biochemical mechanisms that change inside the cells. And these are currently being studied. People have gone to altitude and studied the effect that the chronic hypoxia of altitude has on the body. And patients who are adapted can tolerate remarkably low levels of oxygen saturations in the blood, partial pressures of oxygen in the blood. And the reason they're able to tolerate this is probably primarily due to intracellular changes within the cells themselves. So the body's responses to hypoxia, clinical features for you to look at that indicate the presence of hypoxia.